Hi, everyone. Thanks for joining. I think we're going to wait just another minute or so as people continue to filter in, and then we'll get started.
Okay, I still see we have a couple people still filtering in, but I think we're just going to go ahead and get started in the interest of everybody's time. So welcome everybody. This is a webinar we have put together in order to make sense of the payment mechanisms in ACO REACH, collaboration between Milliman and Aurrera. And these payment mechanisms are things that both of our groups have been receiving a lot of questions about and a lot of discussion around, because they're not the most straightforward mechanism within these models. So we wanted to dedicate a webinar to talk about them explicitly and try to answer any questions that people might have regarding these mechanisms. So during the webinar, feel free to submit any questions you might have to the Q&A or the chat. We're most likely going to address them all at the end of the webinar. So just feel free to submit them there, and then we can take it from there. Okay, next slide, please. So presenters, myself, my name is Noah Champagne. I'm a consulting actuary at Milliman. I do a lot of work currently for ACOs of all types, MSSPs, worked with a lot of next gens, direct contracting entities, and now a lot of ACO reaches. So this is a lot of the area that myself and my team specialize in here at Milliman. Breda, would you like to go ahead and introduce yourself?
Thanks, Noah. My name is Breda Eshelman, and I'm the director of the Medicare team at Aurrera Health Group. We have a number of provider clients who are participating in ACO REACH, as well as other alternative payment models. And before I came to Aurrera, I worked at CMMI for a few years, where I led the next generation ACO model, as well as several other models at the center, and actually helped design the direct contracting model that preceded ACO REACH.
Awesome. Thanks, Breda. Okay, next slide, please. Okay, so just to start at a high level and get everybody sort of familiar with what it is we're talking about here. So I wanted to talk about just the high level payment mechanism options available in ACO REACH. And these are the same mechanisms that were also options in direct contracting, but now looking forward into 2023, we're calling it ACO REACH. So first, global track ACOs, those ACOs taking 100% upside and downside risk. have the option of choosing between either total care capitation or primary care capitation in terms of sort of their capitation participation. They have to choose one of the two, but they can choose between the two. And I'll talk about what each of those are in a little more detail in the next slide. However, professional track ACOs, those REACH ACOs that are taking only 50% upside and downside risk, but without the benchmark discount, they are required to participate in primary care capitation. They're not able to participate directly in the total care capitation mechanism, as it's defined as a TCC within the model. Now, any ACO, whether it's global or professional, that is selected to do the primary care capitation also has the option to participate in the advanced payment option, the APO. And the APO is something that the advanced payment option is something that existed, not a very, very similar name under the next gen models. This is sort of a continuing concept, the advanced payment, whereas the PCC and TCC, these capitation mechanisms, are new in the direct contracting and REACH models. So one thing that, to keep in mind is that, professional track ACOs, electing to participate in PCC can also use the advanced payment option, in addition to the primary care capitation that they have, in order to build a payment structure that looks a lot like a total care capitation mechanism, but with the non-primary care services being covered by this APO, which does have a few different dynamics to it that we'll talk about later in the webinar. Next slide, please. Okay, to go into a little more detail into what TCC, PCC, and APO are. So first, let's talk about total care capitation. And so what happens when you participate in total care capitation is that CMS reduces the claim payments made to providers that essentially agreed to be part of this total care capitation. And it's all Medicare Part A and B services that we're talking about being reduced. And for participating providers, which are those providers that drive claims-based attribution, those participating providers have all these Medicare Part A and B services reduced by 100%. That is, CMS is not paying the providers directly for any of these services. While preferred providers, which are providers that sort of the participating entity can, indicate being preferred, they're able to choose any reduction to the claims that are paid at those providers. So essentially, a preferred provider group could say, well, we want to be paid 50% of fee for service by CMS, and then we'll have the other 50% of services be covered under the total care capitation. And so once all these elections are made, CMS will not pay these claims to the providers, and then they'll provide a monthly lump sum payment amount to account for the claims that were not paid directly to providers under TCC. Now, PCC is relatively similar, same basic idea, but instead of it being all Medicare Part A and B services, it's limited to primary care services furnished by primary care providers. So the definition of these services is quite similar to the services that are eligible for claims-based attribution. So the E&M, evaluation and management services, is essentially what we're talking about. And this list is defined explicitly by CMMI. Now, one of the differences, though, is that participating providers in primary care capitation can choose a reduction percentage. So it's not necessarily 100%. Now, there is a minimum reduction percentage that providers must choose, which is 10% in 2023, and it jumps up to 20% in 2024. But once you get to 2025 and 2026, the minimum election is 100%. So it actually looks a lot like total care capitation just for the primary care services, and that all the providers, all the participating providers, have to elect the 100% reduction. And then preferred providers, similar to under total care capitation, they can choose any reduction. And then CMS will pay a monthly lump sum to account for the claims that were reduced under this capitation. And Breda will talk a little bit more about how that amount is calculated. And then we also have the advanced payment options. The advanced payment option essentially says that CMS is just going to reduce the claims payments for providers that sign on to this advanced payment option. And so it's all non-primary care services. And again, that's because it's sort of paired with the primary care capitation, right? So you can only participate in APO if you're in primary care capitation. So all the primary care services are under PCC, whereas all non-primary care services will be covered under the advanced payment option. And participating providers or preferred providers can choose any % reduction in claims they would like under the advanced payment option. So, large amount of flexibility here. This is not a required participation. You can just elect to participate in the advanced payment. And in exchange for the reduced payments, CMS will pay a monthly lump sum. But the big distinction with the advanced payment option is the lump sum amount that is paid, monthly to the providers is reconciled against actual utilization at year end, which is not, true in the same capacity for the PCC or TCC. That'll be something, again, we'll talk about in a little more detail later on. Okay, I think I'll pass it off to Breda here, and she's going to take it from here.
Great, thank you, Noah. I'm just trying to advance the slide here. There we go. All right, so I'm going to walk through how the TCC, PCC, and APO payment amounts are calculated, and also how they're reconciled. So we're starting off here with how the TCC and the PCC amounts are calculated before the start of the performance year. It's a two-step process. So this slide shows step 1, which is where CMS projects the % of expenditures that they expect to fall under these capitation arrangements. And they base that on the historical % of expenditures that would have fallen under capitation if the ACO had existed at that time. And the look-back period they use for that is January through September of the previous year. So to show an example here, if you look on the left side of the screen, there's it shows how to calculate the TCC payment. You can see here there's 3 participating providers, 3 preferred providers, and 3 providers outside the ACO who serve what would have been ACO-aligned beneficiaries had the ACO existed at the time. The participating providers, as Noah mentioned, must agree to 100% fee reductions. So you can see that their columns are completely in the red, which means all of their claims would have been reduced. Preferred providers can select what % they want. So you can see the first preferred provider selected 100% claims reduction. Their column is completely red. The second preferred provider selected what appears to be about 50%, so about half their column is red. And the third preferred provider selected not to participate in TCC at all, so they retain all of their claims payments. They're completely blue. And of course, providers outside the ACO are not able to participate in TCC, so their columns are completely blue, meaning they would not have had any claims reduction. And when you add all of those together, it would have been about 50% of the total cost of care that would have fallen under TCC in that historical period. If you look to the right of that, you can see the same calculation for what's called the base PCC amount, and I'll explain in a second why that's just the base PCC amount rather than the entire amount. But essentially, here it's a smaller proportion of claims that would have been under the capitation arrangement, both because PCC only applies to primary care and because PCC providers, at least in 2023, are permitted to select reduction percents less than 100. So you could have some participating providers who only agree to have, for example, 20% of their primary care claims capitated. So in this example, that represents 3% of the total cost of care during that look-back period. And now the reason I mentioned that it's base PCC is because there's also an option under ACO REACH, which existed under direct contracting, called the enhanced PCC amount. The base PCC amount, which again is based on the historical % of claims that would have fallen under capitation had it existed at that time, typically is less than 4% of total cost of care. And CMS wanted to give ACOs an opportunity to receive additional upfront money through this payment mechanism if they want to. And so CMS has this option where ACOs can, in addition to receiving the base PCC amount, also opt to receive something called the enhanced PCC amount, which is the difference between 7% of the total cost of care and the amount represented by PCC, the base PCC. So in this example, that would be 4% of the total cost of care. The enhanced PCC amount is a little bit different than the base PCC amount because CMS recoups the entirety of the enhanced PCC amount at reconciliation. So the easiest way to think about enhanced PCC amount is not as capitation, but rather as an upfront interest-free loan that CMS is going to recoup in its entirety at the time of reconciliation. And for the rest of these examples, we're going to just walk through base PCC and ignore the enhanced PCC amount, but just know that that is an option that's available to ACOs. Okay, so this slide, to summarize again, was step 1 of calculating the TCC and the base PCC amounts, and that step was what % of expenditures do we expect to fall under this arrangement? Step 2 is that CMS multiplies that % by the benchmark amount. So for TCC, you'll remember we expect 50% of the total cost of care to be under the TCC arrangement. So if we had a benchmark of $1,000 per beneficiary per month, then the capitation payment would be 1,000 times 50%, or $500 PBPM. And the base PCC amount, we had 3% of expenditures that we expected to be under that arrangement. So we multiply 1,000 by 3% and you get $30 per beneficiary per month. And the one thing I wanted to mention here is just that benchmark does not capitation arrangement. So Noah had mentioned that.
Sorry, Breda, I think you cut out there for a second. Could you repeat the last couple sentences you said on the previous slide? Sorry.
Yes, thank you. On the previous slide, I was just pointing out that the percents that are applied to calculate the TCC and the PCC amounts, those percents are applied to the benchmark, which does not necessarily represent the actual total cost of care that the ACO is expected to have during the performance year, because the benchmark incorporates both an ACO's own historical costs and regional costs. So Noah had mentioned that PCC ACOs also have this option to participate in APO. So this slide shows what that would look like if a PCC ACO elected to participate in APO as well. And here, the green represents claims reductions for that APO option. And remember that providers, either participating providers or preferred providers, can select whatever reduction % they want for APO. And so here, the third participating provider who did not participate in PCC, so this would be a non-primary care provider, elected to have 100% claims reduction under APO. So they have a completely green column here. The second participating provider, the one in the middle, had, it looks like here, they would have had all of their primary care claims reduced by PCC, which is what the red represents, and the rest reduced by APO, which is what the green represents. And of course, preferred providers are able to participate in APO as well. APO, the way that it's calculated is a little bit different than the way that TCC and PCC are calculated, because it does not depend on what % of the total cost of care we expect APO to represent. It's instead based on the absolute value of what we expect those claims reductions to be. So in this case, when you add up all of those green columns together, CMS projects that the value of those claims reductions will be $200 per beneficiary per month. And so the APO payment to the ACO will be $200 per beneficiary per month. So again, that's not based on a % of benchmark. It's just based on the absolute value that they expect those claims reductions to equal. So for this ACO, they will be receiving $30 per beneficiary per month for PCC payments, and then $200 per beneficiary per month in APO payments. And this is where Noah was mentioning that the PCC and APO combination allows for some flexibility for ACOs participating in this PCC option to have a much greater claims reduction percent than you might initially expect. And so ACOs can, to some degree, simulate a little bit what TCC would look like by combining PCC and APO. So with these two payment mechanisms combined, you can reduce pretty much whatever percent of claims that you want for your participating and preferred providers. So the next few slides will go through what kind of reconciliation processes happen for these payments. So as a reminder, the first few slides went over how CMS is calculating these payments at the start of the year. And now we'll talk savings. So one form of reconciliation that happens, which is only relevant to TCC, is that CMS pays attention to the actual percent of expenditures that are falling under this payment arrangement, this TCC capitation, and updates the TCC amount to account for that actual percent of expenditures. So what this is in essence doing is accounting for leakage. If beneficiaries are receiving more of their services from providers who are not covered by TCC, or less services from providers not covered by TCC, then they will update the percent that they applied to the benchmark to calculate that TCC amount. So we'll walk through an example. In this initial calculation that we walked through a couple slides ago, CMS had projected that 50% of total expenditures would be under TCC. And so they'd calculated a $500 capitation payment. But let's say during the performance year that only 30% of total expenditures are actually falling under this TCC arrangement. That means that they'll only be receiving $300 per beneficiary per month. And one thing I want to mention about how that 30% is calculated.
Sorry, I think Breda's having some connection difficulties at the moment, but I can just keep talking here for a little bit until she sort of reconnects here. But you know, what she was sort of saying is, you know, the initial percent of expenditures to be covered under the TCC sort of gets restated based on the actual, you know, emerging percent of expenditures being performed in and out of network. And so, you know, what they do is after, you know, oh, lost the visual there a little bit.
Here we go.
Oh,
can you hear me again?
Breda. Yeah, we can hear you now. Can you go ahead and share your screen again? We lost the screen sharing.
Yes. Sorry about that. Can you see that?
Oh, no problem. Yeah.
Okay, great. So I think I'll repeat the last couple sentences in case I cut out. So I was talking about how the TCC percent gets updated. And so in this example, only 30% of the total cost of care was actually being reduced under the TCC arrangement instead of the 50% that CMS expected. So that means that the ACO this whole time should have been receiving $300 per beneficiary per month rather than $500. And the important thing to note here is $300 does not necessarily represent the value of the claims reductions. So in other words, CMS is not reconciling the TCC amount against the absolute value of reduction that's been making. In reconciling the percent that they apply to the benchmark in order to calculate that capitation payment. So from 50% to 30%, it's only this percent amount that's getting reconciled. Okay. And this takes place 3 times after Q2, after Q3, and then also at reconciliation. And when CMS does this reconciliation during the performance year, payments are both adjusted moving forward and previous payments are reconciled. And so in this case, CMS would recoup $200 per beneficiary per month that they had been paying out in order to make sure that they're reconciling that percent. There's also a reconciliation of APO that occurs, but this reconciliation, unlike TCC, reconciles against the actual value of the claims reductions. It's not a reconciliation of a percent of benchmark. And this happens at the same time as shared savings calculations at the end of the year. So in our example, CMS had projected that the percent reductions that they would apply to claims for APO would equal $200 per beneficiary per month. But it turns out that they only applied reductions equal to $150 per beneficiary per month. So in this case, CMS will recoup $50 per beneficiary per month from the ACO during reconciliation. And again, this is different from the TCC reconciliation of the percent that we just walked through, because this is dollar for dollar reconciling what CMS reduced off of APO claims versus what they paid to the ACO in exchange. One more caveat: when we say that PCC and TCC are not otherwise reconciled, the one caveat is there are some changes that get made to the benchmark. So one example is beneficiary risk scores might change during the year. And in that case, because the PCC and TCC amounts are percents of the benchmark, when the benchmark changes, those amounts will change as well. So in this example, where the monthly PCC payment was 3% of the benchmark, and that benchmark was $1,000 PBPM, if instead the final benchmark is $1,100 PBPM, because, for example, beneficiary risk scores changed, then the PCC amount will be higher. It'll now be $33. And CMS will make sure that that ACO receives the extra $3 per beneficiary per month that they were due at the time of reconciliation. Okay. So we'll now walk through what happens at that time of final reconciliation, where CMS is calculating shared savings or shared losses. I know there's a lot of text on this screen, so I'm going to walk through it slowly, and hopefully it will make sense by the end. So we start in the upper left here. This is an example ACO that had a benchmark of $1,000. And the total value of the care that was provided to its beneficiaries during the performance year was $950 PBPM. And that amount represents what expenditures would have been for those beneficiaries if no capitation arrangements or APO had applied. So between the ACO itself and all of the other providers who cared for this patient population, they provided care worth $950 per beneficiary per month. So under a sort of standard ACO SSP, where capitation arrangements don't apply, this would be a very simple calculation. The savings would be $1,000 per beneficiary per month minus $950 per beneficiary per month, and that would be $50 worth of savings. And CMS would just apply whatever percent sharing to that amount to determine what the ACO gets. But it's a little bit different when we have these capitation and APO payment mechanisms in place, because you have to account for all of those. So walking down this left column now a little bit more. First, the capitation and APO payment amounts, as you might recall, were $30 in PCC payments, and that reconciled APO amount was $150. And then CMS also paid fee-for-service claims outside of these amounts. So this would be to providers within the ACO's network, participant providers, or preferred providers, any fee-for-service claims paid to them outside of PCC or APO, and additionally, any fee-for-service claims that CMS paid to providers not in the ACO's network, but who were serving their aligned beneficiaries. And the reason we backed into this figure of $771.50 because we know that the PCC reductions are equal to 3% of total fee-for-service payments. And so that means that the fee-for-service claims payments understand that number, but we just wanted to is they take the benchmark, which was
Sorry, Brady, you cut up there for a second. Could you, sorry, just step back a couple sentences, sorry.
Yes.
And Breda, maybe it would be helpful if you went off video. It might preserve bandwidth.
Noah, if you can hear me, do you want to take over with these slides since my internet seems to be having some difficulty?
No problem.
Great,
yeah,
you.
so, you know, as Brady was talking about, you know, those fee-for-service claims, the 771.50, you know, where we're getting that is, you know, we have the 3% reduction in fee-for-service payments due to the sort of PCC reductions. And then, you know, the fee-for-service claims made by CMS represent 97% of the total value of services minus the APO. So we have the 97%, which is the non-PCC portion of the fee-for-service payments, times the $950, which was the value of care provided, and we subtract the $150 for the APO payments. And that's how we get to the 771.50. So this is the fee-for-service payments, not including the APO payments. And so under this, we would then get a shared savings where we say, okay, so now the expenses are those fee-for-service payments, the 771.50, plus the capitation and APO payments, which are the $180, the 30 and the 150 there. So the benchmark, and again, we get to this shared savings of $24.25. That's the $1,000 benchmark minus all those expenses, which fee for service plus capitation plus APO. And then we hit that with the 50% shared savings rate. So CMS would measure the shared savings that you would achieve in this as 24.25 PVPM. Now, the other thing to consider is that, you know, you have these shared savings that CMS is measuring, but you also have the savings sort of incurred under capitation. So we say, okay, you know, we have capitated payments received by the ACO, you know, the $30 PCC payments that are received every month. But the value of the claims that were provided to the beneficiaries, essentially the claims that were zeroed out by CMS, were only 3% of the $950, which is only $28.50. So even though, you know, the ACO is getting paid $30 by CMS, we're only talking about $28.50 worth of services that were provided to beneficiaries under that capitation arrangement. So in this case, we're saying there's $1.50 savings incurred under the capitation. Now, you know, we'll discuss in the future slides, you know, how that, you know, there are lots of different ways that may flow through, you know, that 150 might flow to the ACO, it might flow to the providers. There's sort of different ways that could be structured in terms of where that savings goes exactly. And so in this case, if we think about that $1.50 just accruing to the ACO as a whole, the total savings accrued by the ACO would be $25.75, which includes the $24.25 that goes, you know, directly to ACO in traditional shared savings, and then the additional $1.50 coming from the capitation arrangement. Okay, and you know, as Brenda said, and you know, worth pointing out here, this is a little confusing, and we wanted to try to lay it out in the simplest way possible. That doesn't mean this is not in any way confusing. So please feel free to submit any questions. We just wanted to lay out some examples to sort of talk through how this would work and think through an example. And you know, we can share these slides after the webinar, so feel free to, you know, can look at this calculation offline a little bit, but we want to play out the whole scenario. So next slide, please. Okay, so here we had, we wanted to do another, you know, sort of example of a reconciliation under the global track. So this is a very similar situation here where let's say we're participating in the global track and we have two different scenarios. On the left, we have a global track ACO electing to participate in TCC. And on the right, we have the PCC and advanced payment combination. And same values here, right? We're just going to say $1,000 benchmark for argument's sake. And then same value of care provided during the performance year, $950. Again, with the benchmark, you know, we know that under the global track, there's also a discount, but we're just using $1,000 for argument's sake here, just to make our numbers as simple as humanly possible, which still doesn't keep them that simple, unfortunately. So on the left here, when we talk about the total care capitation, we say, okay, and you may recall, may not recall, but the capitation payment we were talking about previously when we were talking about TCC was a $300 PVPM payment to the ACO. And then similar to the calculation we showed under the professional track, you know, what were the fee-for-service claims paid by CMS to providers? In this case, we're saying it's $665. And, you know, again, parallel to the calculation we showed before, that's because the 70% of services that is not covered under the capitation arrangement, 70% of the $950 in services that were provided is about $665. So these are the claims that were actually paid directly to providers. And so then we'd say, okay, the shared savings that CMS would measure would be $35 because CMS would say, okay, benchmark's 1,000. We paid out the capitation and we paid out the fee for service payments. So they paid out, you know, 300 plus 665. CMS paid out $965. So the shared savings that, you know, global track ACOs receive 100% of in this case would be $35 PVPM. And then we have the savings incurred under the capitation where we'd say, okay, look, you know, we received $300 from CMS to cover the capitation payments. But if the services provided under the capitation were 30% of the $950, that'd be $285. So there'd be $15 more received from CMS than, you know, again, technically paid to providers. Again, it depends on the contracts agreed upon, and we can go into that. But in theory, there's $15 monthly, you know, saved under this capitation arrangement. So in total, it's a $50 savings accrued by the ACO. Now, what we want to do here is show how, you know, a similar amount of cash flow here if you do a PCC and APO combination. And this is sort of to illustrate, you know, how you can, you know, build something that looks similar to a TCC here. So in the first row here, we have the capitation and APO payments. These are just the $30 capitation covered under the primary care capitation and the $150 APO payment. So $180, you know, received directly from CMS. We have the fee for service claims paid directly to providers, which is the same $771.50 that we showed on the previous slide, right? The 97% of the $950. And then we also subtract out the $150 APO payment. And so we get this $771 being paid out. In the shared savings in this case, we take our $1,000 benchmark, subtract all the payments CMS made, which were the capitation, the APO, and the fee for service payments, and we'd have $48.50. And then under the capitation, we'd have, you know, the $30 payment made under PCC compared to the $28.50 paid out in claims. Again, hypothetical claims paid out to these providers. And this is important because the $150 that's included here in the APO payment is the final reconciled amount, right? So an APO payment, you know, the example that Breda talked through before was, oh, initially, you know, it was looking like it'd be 200, but then based on actual claims paid out, it was 150. It's important to point out that, you know, what's included in CMS's measure of costs and shared savings is that 150, that final reconciled amount is what CMS cares about because they settle the remainder of those APO payments, you know, during reconciliation. And so, you know, the savings under the capitation here is only $1.50 because it's really the only savings you achieve under the capitation is really the difference between the PCC capitation payment and the PCC claims paid out. And what you can see is that the total savings accrued by the ACO is the same as under the TCC here. It's sort of a different mechanism. You have more money flowing through the shared savings here, but the idea here is this is the same ACO, the same performance, just structured differently, and the payments, the savings accrued by the ACO are roughly the same. Now, there's of course the question of how these, how the payments are made to providers that could make these different, but from CMS's perspective, the sort of shared savings or the savings accrued to the ACO is identical. Okay, next slide, please. We want to dig into here some examples of how these payments can flow from an ACO to providers, and how it could mean different things for providers and ACO depending on how these are structured. So first we want to look at total care capitation. In this example we have, and this is, again, this aligns with our previous example, but I'm sure not everybody remembers all these numbers. But the preliminary estimated capitation amount was $500, and then we decided based on the actual leakage that took place in the performance year, the adjusted TCC payment should actually have been just $300, right? And so CMS will, essentially pay out the $300, right? They adjust old payments, as Barry talked about before. And then the value of services provided under this capitation, the value of the fee reductions, was $285, right? And this is the $15 sort of savings under capitation that we talked about in the previous slide. So each of these columns here represent sort of different structures of paying providers these payments, just to illustrate what this could look like. So the first column here, we have the full capitation amount flows through to providers. So this is the preliminary capitation amount. So, some contracts that people make with providers say, look, we're just going to pay you that preliminary capitation amount, and we're going to take the risk on any adjustments to that or any actual services provided. So the ACO pays the providers $500, which, as you can see here, the adjusted capitation amount is significantly lower than that at $300. So, if the ACO is paying out the providers the $500 and then is only ending up receiving $300 from CMS, then the ACO, accrues a savings of negative $200. They lose $200 on this deal, right? They paid out $200 more to their providers than they received. Now the providers make out great in this situation because, first of all, they get that extra $200, but then they only provided $285 of services to members. So in theory, this is a savings to them of an additional $15 on top of the $200. So it's a combination of the two really there. So that's the best case scenario for the providers and the worst case for the ACO in this specific instance. The next column we say, let's say we're going to look at the actual adjusted capitation amount once the leakage is sort of brought in and we understand what the full capitation amount is. So in this case, the ACO is paying the providers the $300. This is fine for the ACO. This is the amount they receive from CMS, and they turn around and pay the $300 to providers. It doesn't really impact the ACO savings or loss directly. And the providers make $15 because they've only provided $285 of services and are getting $300. So this is sort of a very neutral way to pay providers. And the next column here, we have fee for service payment to providers. So this is an agreement where the ACO, agrees with the providers, we'll pay you fee for service payment rates for all the services you do provide, which, from a provider perspective is no change from before this agreement was in place, right? So basically, the ACO would pay out the providers $285. The ACO would get to pocket the $15 difference between the $300 they received and the $285 they paid out to providers, and the providers have no impact to this scenario, right? They just get paid fee for service as they normally would have. And the last column here is showing what if the ACO agreed with the providers to pay them 95% of fee for service payment rates to the providers. So instead of paying $285, which is 100% of Medicare fee for service, the ACO would only be paying the providers the $270.80, and the ACO would be generating savings now because it would be generating, more savings because they're paying the providers less than fee for service and they're still receiving the $300 from CMS. So they would be saving almost $30 off this payment, whereas in this case, the provider would be losing because they're getting paid less than fee for service, right? They'd be losing $14 in this case. They'd be receiving less. And so this is sort of an illustration of just a few different ways this could flow. Now, again, this illustration does not have to work this way, right? The preliminary capitation amount could be lower than the adjusted capitation amount, and the value of services under capitation could be larger than the capitation amount that you receive from CMS. So I wouldn't focus too much on the directionality of these calculations. This is just an example, but we thought this was a helpful illustration to show, different ways of structuring this payment. Okay, next slide, please. And here we have a very similar calculation to the one we just showed. I'm not going to spend too much time on this, just in the interest of sort of getting through the material and addressing any questions that might come up. But this shows a very similar flow of funds within a PCC and APO calculation. So it's a little different in that the APO does get reconciled, right? Whereas under the TCC and PCC, you just receive the capitation amount. That's essentially what you receive minus the adjustments that Breda talked about before. So I'm not going to step through this calculation just in the interest of time, but feel free to reference this yourself in the slides after the presentation. Okay, next slide, please. Okay, so this is where I want to talk about some considerations relating to provider payments under PCC and TCC. So we've worked with a number of different clients thinking about, you get this payment from CMS, right? Because CMS calculates a single base TCC PCC percentage for the ACO as a whole and just writes a single check to the ACO for that amount, right? And so, this is just a lump sum payment, and basically the ACO needs to figure out how you distribute this to PCC or to the providers that you're contracting with in a fair manner. And there are lots of, wrinkles to this. This isn't necessarily a clear-cut thing, and I don't think there's a definite answer on the best way to exactly pay providers under this arrangement, but there are different things to keep in mind. So, a couple of things that come to mind, I think, just help illustrate some of the difficulty in this calculation are a few questions I've laid out here. So the first one is, how will payments to providers be structured? Okay, some ACOs say, okay, we want to do some sort of discount off Medicare fee for service. Maybe instead of paying 100% Medicare fee for service, we'll pay 95% of Medicare fee for service, right? Or maybe it will be, we'll pay some percent of Medicare fee for service, but that percentage will be set based on some quality performance or something like that. Or you could have sort of more bundled payments based on sort of, bundles of services or certain types of arrangements being provided. I mean, there's a lot of different ways this can be structured, but, it's worth considering that, you can pay a flat capitation amount per member, or you can do a discount, or you can do bundles. There are all these different ways to pay providers under this arrangement. This, CMI is giving ACOs the flexibility to design that on whatever they think would fit best for their network. Okay, the next question is, how does historical PCC/TCC covered service utilization vary by provider? I think this is a big one because, at the end of the day, what's happening is these providers are going to be not paid by CMS for the services covered under these arrangements, right? And so looking at, historical patterns of what services would not have been paid, I think is really important to sort of understand, to design a reimbursement structure that pays everybody fairly for the services that they've provided and not been paid for, essentially. So being able to look at the historical PCC and TCC covered services for each provider, and comparing that to maybe, a hypothetical reimbursement structure that you put in place, shed some light on, who the winners and losers would be and, why. So that's an important thing to think about. And then, has there been any shifts in utilization patterns relative to the look back period, right? CMS is looking at a historical time period to set these percentages. Maybe you have a specific provider who's really shifted their practice patterns and is doing something really different and might expect to see a larger payment in future years than they did historically. So that's something to be aware of and cognizant that could be impacting, the calculation from CMS of the percent of care provided, as well as, how you might be considering distributing payments to providers. Another one is, should payments be linked to attributed members associated with each provider or based on something else? And also thinking about how would you figure out what members are attributed to each provider? And this is something where, I think this comes up a little more when I think about TCC and you say, okay, well, I could just set a payment for each provider based on the members that are attributed to each provider, but you might have one provider who's attributing lots of members, maybe a primary care doctor and group that's attributing a lot of providers, and next door they have a preferred provider of yours that is not attributing any patients, but is providing almost all of the services to the patients that are attributed at that primary care provider. And so what happens is that the facility that's not attributing any members, if you're linking the payment to attribution, they might not get paid at all under the capitation arrangement, but they might have a lot of services not paid by CMS because they'd be covered under the capitation. So just, again, it's just another thing to consider is that sometimes attributed members may not align with the payments that are not being paid to the providers. And next thought is, should there be some type of performance or quality withhold as part of that payment? And then also when those payments will be made. We have these different sort of reconciliation and check-in times, and when will providers be paid for these services? Okay, next slide, please. So this is a quick little example I put together. And again, I know we're sort of running up on time here, so I won't spend too much time on this, but this is an example of a way to look at, provider level PCC or TCC calculations. And what's happening here is we have provider A, B, and C. And this is sort of the example I was talking about where there's no members attributed to provider C, but they still, have a significant amount of PCC or TCC claims in the look back period that were not being paid. You can see in that third column there, $1 million was paid to provider C that would not have been paid. And so one of the ways I like to, that I often think about how to distribute PCC payments is simply to look at these look back periods and look at the distribution of, the actual payment of claims under the TCC or PCC to those providers, and use that distribution of payments to distribute the base PCC or TCC payment. That falls apart if providers are changing practice patterns or there could be other shifts. So it's not a one size fits all, but it's something that I think deals with some of the differences between attribution and PCC and TCC payments that is a relatively simple approach. So this is just an example of how that might flow. So again, feel free to peruse this after the webinar. It's just an example. It just illustrates a way that I've done this in the past. Okay, next slide, please. And so this is just a couple of resources that I just wanted to mention and consider when we talk about ACOs thinking about how to pay their providers. So CMMI provides a weekly claims reduction data feed, provided at claim line level for participating DCs or REACH ACOs. This can be a good data point for monitoring, emerging claims and how the actual claims that are not being paid to providers aligns with the payments that have been made. This is sort of a looking back view of it. And CMMI also provides, historical data at the start of the performance year that supports the development of the base PCC, TCC, APO percentages. So that is a data point. It's not claim line level, so it's a bit harder to dig into a little more, but it helps you understand, what the historical patterns were that led to the actual PCC, TCC, APO payments you are receiving during the performance year. And then a couple other, external data sources that are that can be really valuable here. One is, the CCLF files that CMS provides to DC REACH ACO participants when you're actually participating in the programs. These are, again, claim level detailed files that can help you dig in a little bit more and understand, the patterns of claims between providers and what might be covered by the PCC during a performance year. And another helpful resource we find is the 100% Medicare fee-for-service data set. This is something that Milliman has access to, and we do a lot of analyses on for our clients. It's a way to sort of look at historical claims patterns for providers in excess of what's provided in the CCLF files. The CCLF files can be a bit incomplete for historical time periods. So we like to look at the 100% Medicare fee-for-service data set, both for those historical look backs and also for providers that are not currently participating in an ACO where you might not have as good of data. So the 100% data set has been a really valuable resource there when looking at, trying to come up with different methodologies for calculating these payments. And then also any internal claim records that a participant might have that might help feed this analysis. You might have internal admission data or things like that might help there. Okay, so I think those are a lot of resources that there are obviously a lot of different options here in terms of additional resources, but some things that come to mind for us here. So I think that gets through a lot of the content that we want to cover in today's webinar. I know that this is not the simplest thing, and that's why we wanted to have this webinar, is raise and address some questions that we've heard. But hopefully this was helpful, and feel free to reach out to either of us with any questions you might have, and happy to talk more. I know we have a couple questions in the chat. Breda, I don't know if you want to go through any of those.
Sure, thanks, Noah. And hopefully you all can hear me now that I've turned my video off. We received 2 questions. I typed in answers, but can also respond quickly now. So one question was, when we say that the provider can choose their reduction percent, is it more that the DCE ACO entity and the provider mutually agree on that reduction? And the answer is yes. Both the ACO and the provider have to agree on that reduction and actually have a written agreement stating that they understand and agree on what the reduction percent is. And it's the DCE or ACO that's actually responsible for reporting that amount to CMS, especially in the case where there's actually a choice for the reduction percent, which is not the case for participating providers participating in TCC, of course. And the other question that we received is a really good one, which is, if CMS applies the retrospective trend adjustment to the benchmark, would that update the PCC or TCC amounts at the end of the year? And the tech specs for the direct contracting financial payment mechanisms did not explicitly address this question. And the ACO REACH tech specs have not been released yet. But based on our understanding of CMS's intent, I think it's most likely that if they have a benchmark that's updated for whatever reason, including the application of a retrospective trend, then they would also update the TCC PCC amount at that time. Noah, I don't know if you agree with that. Best guess.
I agree. I mean, I don't think it's abundantly clear, but I agree.
Great. All right. I think that was it for questions. So unless anyone else has any burning questions that they want to submit now, I think we can probably wrap that up. And you'll see here our emails are on this last slide. If you do have questions, please feel free to email us. And we'll be posting this webinar online too. So you can go back and watch it and review the slides if you want to look at anything more carefully. All right, great. Thanks, everybody. Have a good day.
Thank you, everybody.